Well, it's a pleasure to be here with you today, Dr. Robson, and I'm looking forward to our conversation about the use of PARP inhibition in the adjuvant setting in the hormone receptor positive and hormone receptor negative space.
Thank you very much, Dr. Iyengar. But if we don't start calling each other Neil and Mark, it's going to get really awkward. So
Let's do
go
it.
back to that.
Thank you, Mark. I think we'll start with the first step really is to identify a population who might benefit from adjuvant PARP inhibition. I suspect you'd agree with me that we've seen some advances in the adjuvant space in terms of molecular therapeutics, where we're now starting to see longer-term follow-up data, which is looking encouraging in terms of reduction in risk of relapse and prolongation of survival, of course, our gold standard in this space. But let me start by asking you what your practice patterns are for germline testing in the adjuvant or the primary setting to identify candidates for PARP inhibition.
So, the history of who got tested has really evolved over the last 30 years or so. And it began as a very selective kind of testing process. We picked families that had multiple cases of breast or ovarian cancer or very young people. And we thought that that was sufficient to identify most mutation carriers. And what's happened over the years is it's become clear that it's not. About half of the people with mutations aren't found until they themselves present with a disease that leads them to be tested, like triple negative disease or ovarian cancer. And so there's been a real movement to expand the population who's been tested. And recently, a number of professional organizations, it was started by the American Society of Breast Surgery, thought that everybody should be tested, meaning everybody, whereas ASCO and SSO were a little bit more restrictive in that they suggested that we at least offer testing to everybody who's under 60 to 65. NCCN has felt that certainly everybody under 50, but not unreasonable to test. You can certainly offer it to people who are older than that. I think all these kind of guidelines are just basically trying to identify populations in which the testing exceeds some arbitrary threshold. But if you have somebody who is a candidate for a targeted therapy like a PARP inhibitor, it doesn't really make that much sense to restrict the testing. And so, if you have somebody in the early stage setting, for instance, who has high-risk disease, and I imagine we'll talk about that in a bit, then they could be a candidate, for instance, for a PARP inhibitor, and they should be tested. It's not that difficult anymore. And although we're going to talk mainly about early stage disease, if you talk about late stage disease or metastatic disease, anybody who might be a candidate for a PARP inhibitor in the metastatic setting should be tested, and that basically means everybody. So we've gotten much more expansive.
Yeah, it's interesting. I mean, I think, as you point out, because of the availability of a therapeutic now, in my own practice, I've really liberalized who I'm testing, and I think that sort of mirrors the evolution of the guidelines. You having led the field in terms of genetics, I'm curious, your current clinical practice in the primary setting, have you sort of moved towards testing everybody? Are you sticking with the high-risk population, younger population? Are you adhering strictly to the OlympiA criteria? What's your approach in the primary setting?
Well, I mean, certainly, testing is for reasons beyond just therapy selection. And so I have tended to be more and more permissive, I guess is the word, about who I test as time goes on. I think the difference becomes how strongly I encourage people, right? So certainly, anybody who's premenopausal, hormone receptor positive or triple negative, I encourage them strongly to consider it, and actually whether or not they have a family history. And then once they get into kind of the late 50s, early 60s, if they don't have a family history, I'm perhaps less encouraging unless there is a therapeutic reason for it. So I do think it becomes a question of how hard do I push.
That makes sense. And, I think it's interesting because, again, in my practice, I find that a lot of it is also patient-driven, right?
Mm-hmm.
They're coming to us asking us for testing. But I think it's interesting in terms of, you raised the point of how we're counseling our patients. and certainly counseling from a hereditary risk standpoint, but also from a therapeutic standpoint, which I think are subtle differences that patients do grasp. But we also have the possibility or the issue of spending more time dealing perhaps with results that are not clinically impactful. So how do you mitigate this sort of conflict, if you will? It's not really a conflict, but in terms of is there such thing as over-testing? Or are you sort of moving also towards this area of just testing everybody and then counseling accordingly?
I think a lot of it is knowledge base, and also what kind of backup you have, right? I mean, so we at Memorial have been very fortunate that we have an incredible group of genetic counselors and clinical geneticists, and have from the very beginning. So we can do things like our impact project, where we're doing 96 gene panels on unselected metastatic patients, and we've done like 40,000 of them with a video consent. But that's dependent upon having enough genetic counselors on the back end to help the clinicians sort out the complicated results. There's a number of different complicated issues that come in. I mean, there's who do you test and what do you test for, right? And both of those have been a little bit controversial. But most clinicians now, certainly on the oncology or breast oncology space, are perfectly capable of talking to somebody about BRCA testing. I think that information has penetrated. I think what I would hope as a former clinical genetics person is that people kind of knew their limitations. And so if they did run across something that was less familiar to them, they would reach out and have a pathway to reach out to get that additional information. And that doesn't necessarily have to be in the same institution, in the same hospital. I mean, you can imagine other models where people have access to, have access to remote counseling or other types of things. And who knows, one day maybe it'll be all AI and ChatGPT. But, I'm not actually kidding.
No, I think that'll be interesting. I think some of the remote counseling models that have been tested have looked very scalable, and I think your comment is really insightful about a day, which we're probably starting to see already, where AI is assisting those kinds of conversations. I think it's really interesting, the point that you raised, because I know that Memorial certainly has a very strong clinical genetics group that's available for counseling. And in other places of the country where that may not be so readily available, I think remote access is probably the wave of the future. But how do we, for the practicing clinician, let's say that's in the community, and does not have access within their institution or hospital to a clinical genetics team, can you map out for us what the testing paradigm would look like? Are you doing extended testing for everyone? Are you starting off with a risk-based stratification? And then at what point do you involve your clinical genetics counselors, particularly, let's take off your clinical genetics expertise for a moment. Can you walk us through what that testing paradigm might look like out in the community?
I think we're already experiencing what happens out in the community, which is people, a high proportion of people who are coming to us, as a tertiary center, who are having their diagnoses made outside. At least the higher risk patients, the younger patients, have already had their testing sent before they even arrive. And so, one can have a conversation about how much pretest counseling is really needed, particularly if you have a panel, because most people don't counsel for every gene on the panel. Mm-hmm. So I think so we are seeing people where testing is already being done by local clinicians, OBGYN, I have had radiologists send testing before the person got to us. Now, they have the advantage, those patients have the advantage of subsequently landing in a place where there is expertise where maybe others might not. I think that if one is uncertain, then the better part of valor is probably just to restrict the number of genes that you test, right? I mean, if you test for the fairly canonical 9 breast cancer predisposition genes, then you're unlikely to wander into the woods of what to do with some gene that you've never heard of. And also, it's likely that you would have enough local expertise there. So who could a clinician test? Again, I think everybody who's young, everybody who's under 50 could still be offered. And then, in certain circumstances, you might want to extend that if you think that somebody could potentially be a candidate for a targeted therapy intervention, and using clinical judgment about that balance between probability of finding something versus concerns about ambiguous results or difficulties counseling.
That makes sense. Thanks for sharing that insight. One thing that I just wanted to pick up on, which I think is important that you mentioned, is breast cancer subtype. And I think certainly both the hormone receptor positive and triple negative settings are areas where we're using PARP inhibitors in the adjuvant setting. And for my practice, I really don't differentiate too much between the hormone receptor expression status and whether or not I'm testing. I typically use the other criteria that you mentioned to drive my testing. But I want to confirm with you, is there an impact in terms of hormone receptor status and how you look at the testing approach or identification of candidates for PARP inhibition?
Not for me. I think that there has been, one of the first clinical pathologic observations was the association between BRCA1 mutations and triple negative breast cancer. I mean, and that, again, historical perspective, that observation came pretty much at the same time as triple negative breast cancer was being recognized as a distinct clinical pathologic subtype, with its own clinical behavior. And so those two things got kind of merged in people's minds, BRCA1 plus triple negative. And the other thing that happened is that because of the discovery process, BRCA1, which was discovered first, wound up getting more press. And so people didn't think much about BRCA2. I mean, it just was always kind of the add-on. The fact is, BRCA2 mutations are as common as BRCA1 mutations. It is true that 20% of BRCA1 carriers' cancers are triple negative, 80% of BRCA2 carriers' cancers are hormone receptor positive, but that is actually somewhat age dependent. As BRCA1 carriers get older, their cancers are more likely to be hormone receptor positive, and as BRCA2 carriers get older, their cancers are more likely to be triple negative. So it's difficult to use subtype. And again, there is benefit from PARP inhibition in hormone receptor positive and triple negative settings. So I don't think that we should be discriminating anymore. BRCA2 kind of got left out in the cold a little bit. But in some ways, it's more dangerous. There's a wider spectrum of malignancy associated with it. There's a very high risk of prostate cancer. There's a modest risk of male breast cancer. There's a decent sized risk of pancreatic cancer. And BRCA1 is largely breast and ovary. So leaving BRCA2 off the table, and you'd only identify those if you tested a lot of hormone receptor positive patients, would mean that you would potentially lose a lot of opportunities to help people.
Really interesting to hear that historic perspective and evolution.
Historic perspective. You've reached a certain point in your life when you're asked to give the historical perspective.
Well, I think I was going to be kinder and say that I think the field has evolved so rapidly. But I will say that, if we look at subgroup analyses, right, in OlympiA, we see consistent benefit across hormone receptor expression, which is consistent with the comments that you're making. And there was a BRCA1 predominance in the OlympiA population, but I think a question that we commonly receive, or at least I commonly receive, is whether or not there's differential activity between BRCA1 and 2 in terms of PARP inhibition, and I don't think we have evidence that points to that. And certainly in terms of subgroup analyses and outcomes across these subgroups in OlympiA, we saw consistent benefit with PARP inhibition for that stage 2, stage 3 population. So it seems to me that certainly in the setting of the BRCA1 or 2 alteration, this is a therapeutic approach. Are there emerging germline, this will be my last testing-based question, but are there emerging germline populations that you foresee as potential candidates for therapeutics in the adjuvant setting in the future?
Yeah, I think the other potential is in the PALB2 carriers, who, at least in the metastatic study, TBCRC48, which was run by Nadine Tung, there was a very high response rate in women whose metastatic disease was associated with the germline PALB2 mutation. And so there will unfortunately never be a study of adjuvant therapy in PALB2 carriers. It's just not that common. But every piece of evidence points to them potentially benefiting. Conversely, or on the other side of the coin, women who have CHEK2 or ATM mutations probably do not benefit from PARP inhibition. And CHEK2 and ATM are both relatively common if you do panel testing. But unfortunately, those genes don't confer the genetic defect that is needed for PARP inhibitors to work.
Yeah, really important point. I'm glad you raised that because I do hear that question commonly as well, particularly, I think, given the prevalence of those mutations, as you pointed out. So let's talk about treatment in the adjuvant setting. And as we were sort of alluding to earlier, I think our testing and risk stratification certainly sets up the types of therapies that we choose for our patients in the adjuvant setting. Of course, we've seen data for CDK4/6 inhibition, for hormone receptor positive disease, and now we have longer term follow-up data, which is suggesting overall survival benefit with the use of CDK4/6 inhibition in certain populations. But I'm also compelled by the OlympiA follow-up data, longer term follow-up data, which I think shows a very clinically impactful impact both on disease-free survival as well as overall survival with the use of PARP inhibition for our patients with germline BRCA1 or 2 mutations. But let's talk a little bit about the treatment paradigm in the adjuvant setting. And maybe I'll start sort of broadly and get your impressions in terms of how you risk stratify your patients in the adjuvant setting and then use that to select the appropriate adjuvant setting, and whether you do that from a de-escalation mindset or more of a what are we going to layer into their adjuvant treatment, or how far are we going to extend their adjuvant treatment, sort of philosophical questions, I guess. But how do you approach risk stratification in the adjuvant setting and matching with the appropriate therapies?
Yeah, that's a good question. So the entry criteria for OlympiA, which is the study showing the benefit of adjuvant PARP inhibition, were deliberately weighted towards a high-risk population. So, if you had neoadjuvant therapy, it was either residual disease if it was triple negative, or it was having significant residual disease if you were ER positive, as measured by this CPSEG score, which is a kind of a version of RCB coming out of the Anderson group, which nobody actually uses. Then if you were receiving adjuvant therapy, it was T2 or N1 triple negative, or basically N2 or more hormone receptor positive. I mean, the reason that those criteria were chosen was not necessarily because those were the only people who were going to benefit, but of course, in an adjuvant trial with uncertainty about what the benefit was going to be, there was a question of, well, what was the event rate going to be? And so wanted to select a population that was going to have a high enough event rate that you could show a difference. I fully suspect that it will work just fine for people who have lesser degrees of risk. Now, a couple of sort of comments. One is that the trial was designed and executed certainly before Keynote 522, so nobody in there had adjuvant IO. And it was also designed before the CreateX paradigm became well established for people who had residual triple negative disease. So nobody got Pembro, nobody got capecitabine. The hormone receptor positive patients did get endocrine therapy, but they did not get a CDK4/6 inhibitor because it was pre that as well. So now I guess what happens is you're in this situation of, well, let's just say I have a young woman with triple negative disease who has residual disease after neoadjuvant Keynote. What do I do? Do I give them CreateX? Do I give them a PARP inhibitor? And I would suggest that one give a PARP inhibitor in that setting. You can combine it with Pembro. There's tons of safety data. And if you look at the metastatic trials of PARP inhibition, they were compared against physician's choice chemotherapy, and capecitabine was actually one of the most commonly chosen regimens. And the overall response rates were about double. So I think that it's likely that a head-to-head comparison would be favorable for Olaparib, and especially after the ECOG platinum versus, platinum versus capecitabine trial, in which everybody did really badly. The hormone receptor positive space is a little bit more complicated. You can give your standard endocrine therapy along with the PARP inhibitor for a year. The challenge is you really cannot combine it with a CDK4/6 inhibitor because of overlapping myelosuppression. However, if you recall, people who were eligible for either Monarchy or Natalie were able to start therapy well after the time when they started their endocrine therapy,
Right.
more than a year after. So I think that you can sequence them rather than necessarily choosing one or the other. So start with a PARP inhibitor and then go to the CDK4/6 inhibitor. Why not start with the CDK4/6 inhibitor? We at least have some evidence, clinically, and Pedram Razavi has done this with Anton Safanoff and presented it at San Antonio, is trying to actually publish it, showing that in the metastatic setting, women who have BRCA mutations or whose cancer is actually homologous recombination deficient for any reason are less responsive to CDK4/6 inhibition, or at least they have shorter durations of response with CDK4/6 inhibition. So the CDK4/6 inhibitors may not work as well in the BRCA population as opposed to a truly targeted therapy like Olaparib. So since you don't have to completely give it up, you can do it sequentially. I would start with the one that I would believe is likely to be more effective.
Yeah, that was very comprehensive.
Sorry about that. I felt like I was talking too much.
It was fantastic. No, that's fantastic. You really outlined all of the settings, and I think many of the common questions that come up in the adjuvant setting. I just want to go back to your point and reiterate the point about molecular targeting versus sort of using a capecitabine-based approach in the setting of residual disease, particularly for triple-negative breast cancer. Yeah, I think I too am compelled by the data in the metastatic setting, and I think it, at least again philosophically speaking, is consistent with what we seem to be seeing over and over again, and that is that molecular targeting, especially in the setting of the lesion that is being targeted, appears to be the more successful therapeutic route. And I think if we think about the mechanism of PARP inhibition, the mechanism of CDK4/6 inhibitors, and also the natural history of BRCA mutated disease, it would make sense to me that PARP inhibition is a more effective strategy in terms of disease control, at least disease elimination potentially of micrometastatic disease, versus something like CDK4/6 inhibition. So just to be clear, in the triple negative setting, particularly in those patients who are high risk enough to meet Keynote 522 criteria, these are patients who are getting neoadjuvant chemotherapy, immunotherapy with PD-L1 targeted therapy, which of course they continue in the adjuvant setting. And what I'm hearing, which is consistent with what I do, is that in the adjuvant setting, as you're continuing their immunotherapy, in the setting of residual disease, you are also layering in a PARP inhibitor in the adjuvant setting. What about your patients that achieve a complete response to neoadjuvant therapy with triple-negative breast cancer? What are your thoughts on using adjuvant Olaparib in that setting? And I know you mentioned the criteria, the inclusion criteria for the OlympiA trial. Is that what is guiding your decision there, or is it more of a case-by-case decision?
I think for me, it's obviously partly the entry criteria, but I think it's more that one is trying to select a high enough risk population, right? And the numbers, the event-free survival numbers for the patients who are achieving PCR in Keynote are excess of 90%, and so the probability that you're going to materially increment that with a PARP inhibitor, I think, is pretty small. So I don't feel strongly about trying to push into that space. Now, an interesting question, if we're going to be a little bit forward-looking, is like TBCRC. I can't remember which one it was, but it was a study that was presented at ASCO, showing that actually the ctDNA status at the end of neoadjuvant chemotherapy was more predictive of outcome than PCR versus non-PCR. And so if that holds up in a larger study, you can envision a world where people are stratified by residual ctDNA at the time of completion of their preoperative therapy, and then using that again as a marker of risk that might want you to try to intervene. I'm not sure that if one had a patient who had a PCR and then you were following ctDNA and it became positive and you introduced a PARP inhibitor, that's a completely investigational approach, and I don't know whether or not that would work.
Yeah, really interesting. And I think that's sort of a broader question for risk stratifying all of our adjuvant therapies, right, in terms of treating minimal residual disease. But I think that does make sense in terms of triple negative disease with regard to prioritizing the use of PARP inhibition in the adjuvant setting for those patients that are particularly high risk, either by meeting the OlympiA criteria or now in the setting of contemporary practice, considering their residual disease burden after an IO chemotherapy-based regimen. In the hormone receptor positive setting, which you all already nicely laid out your treatment paradigm there, I think, yes, the question does come up quite a bit with regard to sequencing the CDK4/6 inhibitor with a PARP inhibitor. And just practically speaking, as you pointed out, trial design really logistically allows us to give the PARP inhibitor first and then save the CDK4/6 inhibitor for later. But I think it's interesting as we try to reconcile the varying inclusion criterias across the adjuvant CDK4/6 inhibitor trials. We now have ribociclib and we have abemaciclib labeled in the adjuvant setting. With the OlympiA inclusion criteria, there's subtle and not so subtle differences between the hormone receptor positive populations that were included. And so in a busy sort of practice, would you say that if you think your patient is high risk enough to use a CDK4/6 inhibitor and they have a germline BRCA alteration, then go with the PARP inhibitor first and then sequence the CDK4/6 inhibitor? Or is there value to really sort of subtly parsing out the various inclusion criteria? And perhaps there are some patients who you're giving a CDK4/6 inhibitor to and not a PARP inhibitor. This is sort of a long and convoluted question, but yeah. I think my general paradigm is if I feel that they're high risk enough for an adjuvant CDK4/6 inhibitor and we identify a germline BRCA mutation, then I typically do use a PARP inhibitor as my first therapy with endocrine therapy in that setting. But I'm curious with regard to your thoughts, because these are sort of subtle differences between trials.
Yeah, I think that that's a very important point. Like we were talking about at the beginning, the criteria for OlympiA were designed to risk stratify, not because there was a biological difference between somebody who had 3 nodes and 4 nodes, right? So, I mean, it was purely a risk stratification for the purposes of trial design. And I think what you're trying to do in the clinic is find a person who has sufficient risk that they may benefit. And if I recall, the label actually for Olaparib is high risk. The Olaparib doesn't talk about the entry criteria for OlympiA.
Sort of broadly, you define it.
Exactly.
Labeling, right?
Exactly.
Yeah.
So OlympiA defined safety and efficacy, and then now the clinician is the one who makes the decision about whether or not the risk is sufficient to potentially generate benefit. And so your paradigm of if they got enough risk for a CDK4/6 inhibitor, they got enough risk for a PARP inhibitor makes perfectly good sense to me. It's kind of like what we used to do in clinic, right? If they had enough risk for chemo, they probably had enough risk for ovarian suppression. It was the same kind of paradigm, just a very straightforward algorithm. So I think that's a good way to look at it.
It's interesting how our general disease treatment paradigms or philosophies tend to hold up, though the therapeutics get better. So, I think that also in that setting, in the hormone receptor positive setting, we think about types of endocrine therapy, what we're choosing in terms of the CDK4/6 inhibition. So I think there are, of course, all kinds of other decisions going into how you're combining these therapies and how you're sequencing these therapies. But maybe we'll shift to, in that same vein, toxicity, because all of these different therapies have varying or different side effects or adverse effects.
Right.
I was really impressed. Maybe we'll start with the less common long-term adverse effects, but certainly a concern with regard to our high-risk patients who receive anthracycline-based therapy and then who go on to receive myelosuppressive or myelo-altering therapies. This was a concern for PARP inhibition, is the development of secondary myeloid disorders like MDS or AML. And I was impressed by the lack of identification of a higher risk of developing myeloid disorders or cancers in the longer-term follow-up of OlympiA. In fact, I think numerically, the number of AMLs was slightly higher in the control group. And so do you buy this? What do you make of sort of long-term risk in terms of, let's start specifically with myeloid disorders?
Well, I mean, yes, I mean, you outlined the observation, and it's the same from the metastatic trials, which was there really wasn't a significant number of AML MDS that could be associated with the PARP inhibitor. There is a definite increase in risk, but it seems that a lot of that is coming out of the ovarian population. And this is completely speculative, but the ovarian population would often get repeated exposure to carboplatin before they would wind up getting a PARP inhibitor. And at least in days gone by, a lot of the breast cancer patients did not.
Yeah.
And so whether or not our embrace of platinum-based therapy, or at least our temporary invasive platinum-based therapy for triple negative, is going to have an impact on this later on remains to be seen. But at least so far, with the therapies that were being used during the OlympiA era, that wasn't being seen. No increase in risk with that. And no increased risk of other malignancies either.
Yeah, and taking that point even further, I think looking at secondary or second primaries, both in terms of breast as well as ovarian cancer risk, we saw a reduction in those risks in the OlympiA trial, as I think we would anticipate.
Right.
So perhaps a secondary benefit for this high risk group, genetically speaking.
If I can comment on that, I mean,
Yeah,
it was a numerically lower risk. That is true. There were still ovarian cancer cases in the OlympiA group, in the PARP inhibitor group, and during the course of the trial, nearly half of the women underwent bilateral mastectomy, and something like 79% had undergone oophorectomy. So we're not going to really be able to get a great look at the true preventive effect of Olaparib in this population. And unless we did, I would be particularly nervous about counting on it to do ovarian cancer risk reduction. I think, unfortunately, we still need to be recommending preventive oophorectomy, maybe salpingectomies, to particularly the BRCA1 carriers who are at risk in this age group.
Such an important point. Thank you for highlighting that. I'm certainly recommending, as you pointed out, BSO in this high-risk group, despite the use of a PARP inhibitor. Do you think that you mentioned the breast cancer risk, at least for second primaries? Does this impact in any way your counseling with regard to the surgical decision in terms of prophylactic mastectomy?
Not really.
Yeah.
I mean, I think the surgical decision about prophylactic mastectomy, in my experience, is not conditioned upon a particular level of risk. I mean, it's a shared decision with a patient about her tolerance for the fact that she is at increased risk, full stop.
Yeah.
And, I have yet to see a woman who would make a different decision if you told her risk was 20% or 25%.
Right.
So once you exceed some certain subjective level of risk, people are going to do it. And unless you can guarantee them that the preventive approach is going to give them zero risk, I'm not sure it's going to impact their decision making.
Fair. Yeah, I think that's a very fair point. And I sort of view this almost as icing on the cake, if you will. We're certainly treating the primary breast cancer, but perhaps having some additional preventive benefit as well. So just going back to the adverse effect question, I've certainly found that PARP inhibition seems overall to be well tolerated in the adjuvant setting. You mentioned myelosuppression as something we have to watch out for. Certainly some nausea and fatigue and kind of the usual AEs that unfortunately pop out with most of our therapy sort of popped out in OlympiA. But anything else that you would mention for clinicians to keep in mind as they're counseling their patients with regard to the decision to use a PARP inhibitor?
I think you covered the big topics. So when you start the therapy, there's frequently a period of kind of low-grade nausea, and so we give people preventive antiemetics, low-grade antiemetics, compazine or something like that, so that they can bridge themselves. That usually tachyphylaxis after a few weeks, and then after that they're okay. The blood counts, the biggest issue actually is anemia. And almost everybody who goes on a PARP inhibitor will develop macrocytosis. So you'll see that. And the problem with the anemia is that it can be sudden. In other words, they can be plugging along at a hemoglobin of 10, 9.8, something like that. And then the bottom can suddenly drop out, and you can be in a place where you need to give transfusions. So unfortunately, one does need to both continue to monitor counts during the course of therapy. I usually monitor them monthly, and then have patients be aware that if they suddenly start feeling short of breath or have trouble with exercise tolerance, that this could be one of the possible causes, and they need to get evaluated for it.
Yeah, absolutely. I have not seen any compounding toxicity you discussed earlier with regard to combining immunotherapy with PARP inhibition, and certainly not with combination of endocrine therapy. Is this consistent with what you're seeing?
I counted once how many trials there were of combination PARP and Pembro, and it was large. It was like 40 trials, and there's no safety signals. And same thing with endocrine therapy. There's no real reason to expect any overlap apart from CDK4/6 inhibition. So I have no concerns about combining them.
And I think we're anticipating the final results of OlympiA in 2029, but I think it's safe to say that the results thus far are quite clinically impactful. So I think we've really covered risk stratification and therapeutic targeting in both the hormone receptor negative and hormone receptor positive setting. Maybe just asking a forward-looking question here, but we're certainly seeing, again, that rapid evolution of adjuvant therapies and now perhaps use of novel endocrine therapies in the adjuvant setting, and looking at mutational or genomic alterations that occur in response to our therapies, right? Specifically thinking about the ESR1 mutation. Maybe leave us with a forward-looking statement in terms of how you anticipate the adjuvant setting to look, let's say, a year from now even. You had very insightfully mentioned MRD testing and identification of residual disease potentially as a stratification factor. But perhaps we could take that a step further and look for the evolution of resistance mutations and alter our adjuvant therapy accordingly. But maybe with the perspective of those patients with germline BRCA mutations, which my understanding is what's really driving the natural history of the disease, do you see a change in how we might use adjuvant PARP inhibition, and how we might layer in new types of risk stratification and new therapies coming down the pipeline?
Right. That gives me a wide field to run in. I think so. I think the immediate, most practical decision that will have to be made is if the topotecan ADCs find a role in the residual triple-negative disease. BRCA deficient cells are very, very sensitive to topoisomerase inhibition, and you cannot combine a topoisomerase inhibitor and a PARP inhibitor because there's sort of almost synergistic toxicity. So I think that decision will need to be made. Is if you have a triple negative patient with residual disease, should you give that person however many cycles of an ADC versus PARP inhibition, and that will become a tough call. And whether or not you stratify that call based upon MRD, whether or not, how we make that decision, I think is going to be a conversation, because I don't think that there's going to be a trial that's going to answer it. In the hormone receptor positive space, I mean, if the main thing that happens is we start using oral SERDs as opposed to AIs, I don't think that's going to have an effect, because there's not going to be any significant overlapping toxicity from that. And so we'll just be swapping out one non-interacting endocrine therapy for another. I don't actually see adjuvant PI3 kinase inhibition coming down the pike anytime soon, unless we develop more less toxic drugs. And we've sort of talked about the CDK4/6 inhibitor landscape. So I don't think we'll see as much impact in the hormone receptor positive space, but we are going to have some decisions to make in the triple negative space.
Yes, certainly will be very interesting times as more data comes through. But I think this has been really insightful to hear your comments with regard to the treatment paradigm in the germline BRCA1/2 altered setting. And I think we certainly covered data, particularly from the OlympiA update, which fortifies really the NCCN Category 1 preferred recommendation for using PARP inhibition in our patients that are higher risk and that have germline BRCA1 or 2 alterations, both in the hormone receptor positive and negative settings. We're going to see a lot of evolution, as you alluded to, in the adjuvant space. And I think for now, we're certainly helping our patients by targeting this pathway in those patients that have a BRCA1 or 2 mutation. So I really enjoyed our conversations today, and I suspect we'll be back together again talking soon as we get the next big trial update in this very exciting space.
Well, thank you for having me. It's nice to talk.